We now move on to our next session, a keynote address. It's our honor to welcome Dr. Asha Rao, Director of Rao Hospitals and Care, Coimbatore. She is the past chairperson of the Endometriosis Committee, FOXY, and has served as the organizing chairperson for prestigious events such as UA FOXY and ISAR Conference. Today, Dr. Asha Rao will be delivering a keynote on the topic Optimizing Fertility in Adenomyosis. A very warm welcome, Dr. Asha Rao.
Good morning, dear friends. First of all, let me congratulate Dr. Jayakrishnan and the team for having had such a wonderful conference for last 2 days, which I have really enjoyed. I think I'm coming to Trivandrum after almost 20 years, and it has been a wonderful time here. And I also thank them for having given me this topic of adenomyosis, which is my favorite. Yeah. The adenomyosis, the disease which is more than 200 years old, yet we have dilemmas in diagnosis and difficulties in management. The hallmarks of the disease used to be menorrhagia and dysmenorrhea, and we called it a disease of Paris women, but today more and more we are associating it with infertility, and whenever there is repeated implantation failure or pregnancy loss, one has to definitely halt and look for adenomyosis and then proceed. Because it's seen more and more in younger women, even 30%, and also diagnosed in 22% of infertile women less than 40 years undergoing ART. The exact incidence is difficult to find out because we do not do HPE histopathology for everyone. 21% of women with endometriosis could be having adenomyosis. 28% of subfertile population has adenomyosis alone, and almost 50% of women with subfertility, dysmenorrhea and or menorrhagia could have adenomyosis. You can see that the incidence is rising. Is it because of better diagnosis, because we are doing imaging with a high resolution ultrasound, or is it because we have shifted our fertile years from 20s to late 30s? Perhaps both. Because today I see most women are around 35 to 38 when they come seeking fertility. They said, okay, we got married 1 year, and now I'm coming to your clinic and she's already 39, 40, 41. It's quite devastating to see patients coming at a later age group, and they also have higher chance of endometriosis and adenomyosis. And what is the effect of adenomyosis on fertility? This is a beautiful paper from Tulandi et al., which said lower rates of successful implantation and increased risk of pregnancy loss, thus translating into an overall significant reduction in live birth rate. So less implantation, more miscarriage, so less chances of take-home baby rate. And according to this paper by Verslin et al. In 2014, the miscarriage rate after ART was 14% without adenomyosis, whereas it was 32% with adenomyosis, which is quite high. And another paper by Nirjanakis et al., poor implantation, poor placentation leads to infertility, miscarriage, and you also have all the obstetric catastrophes like preterm labor, preeclampsia, IUGR, cesarean sections, NSU admissions, placental problems, PPH, even up to cesarean hysterectomy can happen because of adenomyosis, and time to time I'm sure you would have faced this problem. And adenomyosis, all of us know the definition: diffuse enlargement of the uterus due to benign invasion of the endometrium into myometrium. With myohyperplasia and hypertrophy, it can be focal or diffuse. And here you can see the beautiful junctional zone, and adenomyosis is a disease of the junctional zone. And the junctional zone is barely 4 to 5 millimeter in normal women. So when it exceeds 10 millimeter, you suspect adenomyosis, and if it's more than 12 millimeter, you can diagnose adenomyosis confidently, because some of them may not have lesions in the myometrium, whereas they could have thickening of the junctional zone. So it's very important to do a good ultrasound and look for thickening of the junctional zone. And how does adenomyosis cause negative impact on fertility? It can be at anatomic level, cellular level, and the level of junctional zone. At an anatomic level, you have the enlargement of the uterus, distortion of the fallopian tube, decreased sperm transport, decreased implantation, and at the cellular level you can see The factors which are favorable to implantation are decreased. You can see here, HOXA 10, integrin, interleukin 10, etc. are decreased, and the factors which are adverse to implantation are increased. So there are lots of changes at the endometrial level, and you also have changes in the junctional zone. Here you can see the thickened junctional zone. There is increased peristalsis, and this is more often because of the hyperestrogenism, and there is also a thickening of the myometrium. So apart from hyperestrogenism, there is progesterone resistance, decrease in progesterone receptors, chronic inflammatory changes leading to poor endometrial receptivity and impaired decidualization. And what about the muscular layer? You can see there can be varied changes from slight expansion of the junctional zone to massive myometrial hyperplasia, like you see here. And this can alter the plasticity and tonus of the uterus. And all your problems of hyperperistalsis, menorrhagia, dysmenorrhea, poor implantation, miscarriage, all this could be also because of these changes of myohyperplasia. So it's for optimizing fertility, it is very important to have early diagnosis. And today, most of us have the good ultrasound at our clinics. You can diagnose adenomyosis with ultrasound with 80% accuracy. If you have 5 out of these 7 markers, you can diagnose adenomyosis. But do not wait to diagnose it with 2D like this. You see here the big adenomyosis uteri, and you do not wait until this. You should, all of us, definitely learn to do a good 3D ultrasound. And here you can see the this is an endometrium, this is a myometrium, this dark area is the junctional zone, and here you can see the early infiltration by adenomyosis. Here this is the focal adenomyosis, and if you use a Doppler, that will help you to demarcate between the myoma and the adenomyosis. And today we also have elastography, so it is quite easy to diagnose adenomyosis and also study the junctional zone, because whenever the junctional zone is less than 10 millimeter, the pregnancy implantation rates could be as good as 45%, and when the junctional zone went beyond 10 to 12 millimeters, your implantation rates could drop down to 16 and 5% according to Puers et al. So that's how today patients with endometriosis, many times we do a down-regulated HRT, because you can suppress the junctional zone and then do the embryo transfer, and your success rates would be better. MRI, of course, could be more accurate, but today I feel that ultrasound is pretty good. And how to help these women to optimize fertility? Conservative surgery, which is being tried almost in 1952, medical management and ART, maybe in combination, but we do not have proper guidelines regarding the efficacy of different treatment options for adenomyosis. Which is better? Is it surgery? When do you operate, or when do you give medication? There are no proper guidelines, but we can see that with experience slowly it is evolving. But ART is coming to our rescue more often. So early diagnosis is important, and segmentation of IVF and then frozen embryo transfer is very important, because it gives you time for uterine volume reduction prior to embryo transfer, which is very important, to reduce the uterine volume before embryo transfer, because that's the one which improves your success of pregnancy rate. So surgical management is being tried since 1952, but today more and more we are trying to do it medically, avoid a scar in the uterus. Coming to medication, NSAID and OCP are more of given in patients who do not want pregnancy. Danazol was a favorite of yesteryears. I remember in 1992, we had this girl who was married for 16 years, yet she was only 34 years, came with severe dysmenorrhea and infertility, and by hysterolaparoscopy, we could see a globular enlargement of the uterus up to 12 weeks with bilateral corneal block, no endometriosis. And those days, we could offer her only Danazol. So when we stopped Danazol after 4 months, she promptly conceived, and the girl child born in 94 is a 31-year-old busy executive today. But this wonderful medication lost its popularity because of the androgenic side effects. And today we have GnRH analogs, antagonists, Dynogest, aromatase inhibitors, intrauterine system with progestogen, ART, and you also have non-surgical procedures like uterine artery embolization and HIFU, which can help you to improve the fertility. Coming to GnRH analogs, this has been my friend in the fertility clinic almost since year 2005, I would say. That's almost 25 years. And when you use pre-IVF GnRH analog for 3 to 6 cycles, it optimizes the ART outcome. That is hypoestrogenism. It decreases the expression of cytochrome P450 in the utopic endometrium of women with adenomyosis, decreases the expression of nitric oxide synthetase, and after 2 to 6 months of GnRH, the uterine volume came down by almost 60%, from 180 ml to 86 ml in the paper by Zhu et al. And we also at Rao Hospital have observed this wonderful suppression of uterine volume. There are very many papers by various authors like Nelson, Corson, Zhang et al. Everybody has used at various intervals like 1 month, 5 months, 4 months. So most often we do not use it for more than 1 year because of the fear of bone density suppression, and you should always give add-back therapy like norethistone 5 milligram along with GnRH analog, which is very important. And paper by Neo et al., which said that you can see here, the implantation rate went up from 16% to 32%. Ongoing pregnancy rate went up from 21 to 48%. And pregnancy rate also from 24 to 51% whenever they used GnRH prior to embryo transfer in patients with adenomyosis. Of course, the number of days of stimulation and dosage may be slightly higher if you use a long protocol. And the chance of miscarriage are also increased in the setting of adenomyosis, and by giving pre-embryo transfer GnRH analogs, you can reduce the chance of miscarriage and also improvement in the pregnancy health. So that means reduce miscarriage and reduce chances of preterm labor also. So which protocol is the best for ovarian stimulation? For a long time, we were depending on the ultra-long protocol. I remember we told them that, okay, we'll dry up all your toxic molecules when we suppress them for 3 to 5 months. And then, of course, I had to even cancel one cycle because she had such a poor number of follicles coming up. So though Salam et al. Claimed a high success rate, later we realized that due to ultra-long protocol, there may be less number of oocytes, increased cost, cancellation of cycle. So today it has lost its popularity, and you definitely cannot use it in many women with poor ovarian reserve, which is pretty common in patients with endometriosis. So today we are using antagonist protocol and sometimes the long luteal protocol, and very rarely we are using the ultra-long protocol. And what about the embryo transfer? We again favor frozen thawed embryo transfer. You can see here in fresh transfer without GnRH suppression pre-treatment, the pregnancy rate was 25% and 29% in fresh transfer with GnRH pre-treatment. But FET with GnRH pre-treatment, the success rate was 39%. So it's quite an improvement because of pre-ART suppression and frozen thawed embryo transfer. This is what most often we are following today in patients with the adenomyosis. This is one of our patients with quite a fairly big adenomyosis of 4.7 centimeter and impinging on the endometrium. So whenever I put this in the panel discussion, my doctors tell me, let's do a hysteroscopic adenomyomectomy, very tempting. But all that we did was, we vitrified the embryos and gave her GnRH suppression for 4 months. And then we did the embryo transfer. And today she is a happy mother of 5-year-old child. So what should be the uterine volume in cases of adenomyosis before embryo transfer? There are no proper answers. Paper by Siako et al. In 2021 says that more than 98 ml before embryo transfer, the pregnancy rates were lower, like 25% compared to 43% in women with smaller uterus. And the incidence of miscarriage also was higher, 51% in a bigger uterus compared to 16% in a smaller uterus. And their yardstick seemed to be 98 cc. And one more paper in 2023 says that Uterine volume at 8 weeks of gestation should not be more than 130 cc. If it is more than 130 cc, the chance of miscarriage are higher. But in my own experience, we have seen good pregnancy rates even with the 150, 200 cc uterine volume sometimes. So, of course, we need more RCT regarding the uterine volume. What about Dynogest? Dynogest is a wonderful medication tried for almost a decade now. Pretty good for managing dyspareunia, chronic pelvic pain associated with adenomyosis, but not very good for controlling menorrhagia or for reduction of uterine volume. And this is a paper by Matsushima et al. They did a 16-week study of GnRH analog, low-dose estrogen progesterone and Dynogest. And before treatment with GnRH analog 307 cc and after 16 weeks 177 cc. Whereas with the OCP and Dynogest, there was no change at all. You can see 220 cc and here it is 230 cc, and Dynogest also no change in volume in 16 weeks, because you cannot wait for a couple of years in these patients. Because in gynec patients we say that okay, after 1 year the volume was reduced by 10%. That's not enough. Here you need a rapid reduction of uterine volume. So GnRH analog worked wonders, not so good with OCP or Dynogest. Aromatase inhibitors seem to be quite helpful in the resistant cases of adenomyosis. You can use 2.5 to 5 milligram per day. Most often you use it along with GnRH analog, and a reduction of uterine volume was seen by 60% in the paper by Kimura et al. And I am also pretty impressed with the combination of GnRH and aromatase inhibitors in reducing uterine volume. But again, it causes profound hypoestrogenism, this combination. So again, you have to add back regime. Maybe you can give 5 milligram of norethistone along with this combination. And the combination of aromatase inhibitor plus GnRH analog in the paper by Bracia et al., they had a success rate of 48% pregnancy rate compared to 20% in the Dynogest group. And this is one of our own patients. She had secondary infertility, diffuse adenomyosis, severe dysmenorrhea, and normal male factor, and she had this enlarged uterus which was almost 344 cc with the adenomyosis of 7.5 into 4.4. Quite tempting. Damodar says sometimes, Amma, shall we go for adenomyomectomy? But I would say no, let us go for medical management first. Let us try our best. She came to us during the COVID years. So Jan 2020, she had the egg collection, vitrification, and from February to September, for 7 months we suppressed her with 2 doses of 11.25 followed by 3.75 along with norethistone and letrozole, and the uterine volume came down only up to 200 cc, 204 cc, because everybody gets fed up. It's already 8 months, and we did the embryo transfer and she conceived and she did wonderfully well. We were all wondering 200 cc, maybe, I was very sure that she'll go in for a miscarriage. Very, very sad to see women having a miscarriage at 20, 22 weeks. If it's later, 26 weeks onwards, you can save the baby, but this lady went off very well. And you can see that thick myometrium, adenomyosis, and this early pregnancy. And here you can see one of the prognostic factors is that if the myometrium is thinning out compared to what it was in early pregnancy, it's a better prognostic sign. So this is at the time of NT, and she had a term section, and the child is today 4 years now, born by October 2020 during the COVID year. And what about Mirena? Initially we thought we could use it only for our gynec patients with the menorrhagia and dysmenorrhea, where it works very well. But we have used it in quite a few patients with infertility, especially with the slightly thicker endometrium, larger uterine cavity. It can also be used along with GnRH analogs. We had the combination of we had the combination of GnRH analog and intrauterine device. And this paper by Wong et al. Shows that the pregnancy rate went up from 33 to 44% after use of intrauterine device, followed by frozen thawed embryo transfer. and ongoing pregnancy rates also from 29 to 41%. This is 2019. This is one of our own patients, 31-year-old, severe dysmenorrhea, married 4 years, male factor normal. She has had an open myomectomy earlier for 11 centimeter myoma elsewhere, and she had good ovarian reserve. We did her egg collection and we gave her JNRH analog 11.25 followed by embryo transfer, which failed. And when she came back to us, we realized that her uterine cavity was still long. It was almost 10.6 centimeter. And we gave her another shot of Lupride 11.25 JNRH analog with intrauterine device because her endometrium also was thick. And after 6 months, we did her embryo transfer, and this time she conceived, and her child is 3 years now. So do not hesitate to give a combination of treatment, because I still feel it's better than surgical correction, because you have no fear of the scar rupture. And even if you do a surgery, you have to wait for 6 months. So may as well do not make them spend 1 or 2 lakhs for surgery and make them wait for 6 months with the fear of scar rupture. I would rather treat them medically as much as possible. Today we have GnRH antagonists, but we have them only for about 3 months. So it is too early to say anything, but I have already seen that patients are enjoying pain relief, and volume reduction also seems to be good in adenomyosis. I think I need some more time before I say more about the antagonist, because it's exactly 3 months since we have been using it. And hysteroscopic ablation, yes, you can try for submucous cysts, but more often for our gynec patients. And uterine artery embolization, earlier all of us used to fear, but today there are good series coming out where they have seen 39% pregnancy rate, live birth rate also was 69% in this particular paper. And HIFU is being tried, and I think yesterday we had Dr. Selva talking about HIFU. Many centers do not have HIFU, so once again I cannot comment on my experience of HIFU because I have no experience. So with all this medical management around, who will require surgery? No, even up to 200 cc uterine volume we had pregnancy. Though Zhang and Siaku claim that you can, the maximum uterine volume could be 98 or 113 cc. Even with 200 cc we had good pregnancy rates. So in our clinic, we try to minimize the surgeries as much as possible. In general, a well-defined adenomyoma of more than 5 centimeter, because I've heard some senior doctors get up and say more than 3 centimeter medical management does not work. That's not true. It can work very well. Like I showed you earlier, even 7 into 5 centimeter adenomyosis regressed very well after medical management. So well-defined adenomyoma of more than 5 centimeter, recurrent miscarriage or recurrent implantation failure IVF, which is not responding to medical management. So if it is not responding to medical management, that's the only time that you have to go for surgery. So lots of methods are coming, 3 petal, 4 petal, but in this series by Tan et al., we have seen that the rupture rate could be as high as 6.8%. After cesarean sections, the rupture rate is 0.1%. After myomectomy, it is 1%. Here it could be 6.8%, because not everybody is much experienced like one of the senior doctors. Many are young and innovative. You go and do a adenomyomectomy, and then we have seen ruptures in some of the neighboring clinics. So as much as possible, though we have good surgeon available in our center, I would always try to do a medical management first, because of the fear of scar rupture. And of course, sometimes the people are claiming you can put a mesh, yes, but nothing like avoiding a surgery. And anyway, you have to wait for 6 months, whether it is surgery or medical management. Medical management sometimes smaller adenomyoma, maybe you just wait for 2 or 3 months. So according to Osada, focal adenomyosis, he is okay with laparoscopy, but diffuse adenomyosis, he prefers laparotomy. He has never had any rupture in Osada series. But today again the skill is growing, so we see the Indian surgeons are very good in adenomyomectomy, and better results are coming out from surgical therapy also. So this was our paper in 2016, and later we have, this is 56 cases. Later we published a paper of 100 cases in the magazine, And we had a live birth rate of, we had a pregnancy rate of 44% with a live birth rate of 68% with adenomyosis, which is pretty good. And this is one of our patients, 39-year-old, infertility of 15 years, and she has had adenomyomectomy elsewhere, and she also had a failed IVF before she came to us. She was already fed up because she was operated a couple of times earlier for endometriosis. So exhausted ovaries. You can see the size of the, no, this is really an old picture, which was 2006. Almost a 6 centimeter adenomyosis, and she underwent suppression by 2 doses of 11.25 GnRH analog, suppression for 6 months. Uterine volume came down, and then she had the embryo transfer, egg donation, and she conceived, in fact, 2 embryos became 3. Of course, I would love to transfer single embryo, but with her multiple failures earlier, we transferred 2 embryos which became triplets, and there was a spontaneous reduction of 1 twin, and she delivered. She had a section at 37 weeks with 2 good size twins, 2.7 and 2.2 kg, not a diabetic. So she did very well, a patient with previous adenomyomectomy and failed IVF. This is another lady, one of her own patients. She was married to her uncle. So consanguinity, and she had, I think, 5-6 miscarriages, 1 or 2 neonatal losses. She came to us at 40 seeking egg donation because she said, I have married my own uncle. I'm not willing for further tests and chromosomal, this, that. No, I have no money. So I have come to you for egg donation, help me. Because she doesn't want to change the sperm in spite of multiple miscarriages. So we initially tried medical management, and 3 IVF failed, and 1 of them was an early miscarriage. So we told her, no, definitely you should undergo a adenomyomectomy, at which point she disappeared. And she came after 6 months again with menorrhagia and anemia. And then she was willing for surgery, so we gave her, those days we did her adenomyomectomy, which was open adenomyomectomy because it was in 2008. You can see here, she had a laparotomy and debulking. And 2008, she again conceived with ICSI with the husband's sperms and egg donation. And she had twin girls at 34 weeks in 2009, both healthy. So there was happy ending. This is another patient with posterior wall adenomyoma. This was a cystic lesion. So many times people tell me, oh, this is a chocolate cyst in the myometrium. It is not. It is a cystic lesion of adenomyosis, which is called adenomyoma. Secondary infertility. And we did her laparoscopy and drainage, fulguration, and the GnRH suppression. And after 6 months, she had a spontaneous conception and live birth. And again, this child is about 14 years old. And this is another lady who has had multiple IVF elsewhere, 39 years. In her married life of 8 years, I think she already had laparotomy twice, laparoscopy thrice, severe dysmenorrhea, thick endometrium. She had, I think, previous 5 IVF failure elsewhere. She had a diffuse adenomyosis with thick endometrium. And initially we tried Dynogest. Though I did not like Dynogest, I said, okay, let me try. We tried Dynogest suppression and with the intrauterine device. And we did an embryo transfer. It did not work. So later this lady, again, we gave her our favorite GnRH depot. And then we did the embryo transfer. So our second IVF, her 7th IVF, she delivered a female baby, and it's a happy baby in Tanjore. So when women come to you with adenomyosis associated infertility, if they are young, small adenomyosis, normal male factor, do a routine workup, treat them like anybody else, maybe just a couple of periods of fertile period they will conceive, or even IUI they may conceive, so do not suppress them in case of small adenomyosis. But if it is more serious problem, then you can give a long protocol, GnRH agonist suppression, and when you stop it, they may have a natural conception. If there is no pregnancy, you can go in for IVF. So try IVF and frozen thawed embryo transfer. And if there is no success in spite of 2-3 IVF, this is the only time that you are going for surgery. So I would like to avoid, I would like to be selective. I wouldn't say that we have not done, we have done quite a few adenomyomectomies, but be choosy. Most often your medical management will work. If it does not work, then you go in for surgical management. So the same thing is said by Duham et al. You can see here in the series, actually she says, standard ART, if it is mild disease, 2 to 3 cycles of ART, cryopreservation, GnRH for 2 to 3 months. And sometimes she even talks about 1 to 6 cycles. Maybe it is done by the government in the Nordic countries, because there everything is free. In India, I do not think you can afford to do 5 to 6 cycles, but you can see once again they are very much for conservative management rather than adenomyomectomy. So to summarize, coexistence of adenomyosis may have a significant impact on fertility. Pre-treatment with GnRH analog, today we have antagonists which we have begun to try. So medical management seems to be beneficial in improving pregnancy rates and improves fertility outcome. The benefits of fertility preserving surgery vary greatly, to be performed in selected patients and trained hands, which is very important because do not experiment on these young women. So these are the 2 books which published during my tenure as the endometriosis committee chairperson, the Foxy Focus. I'm sure quite a few of my friends, Dr. Venugopal, Kunjamoideen, have contributed to this book on Foxy Focus. Also Dr. Amit Patki. And these are the guidelines that we brought out during my tenure. And I'm very happy to welcome all of you to UTI Foxy 2025. This is June 20 through 22nd. I'm sure many of you could brush up your nostalgic memories of your honeymoon. So please do come with your friends and family, and let us have a very good session of Foxy's South Zone Conference in Ooty in the 3rd week of June. Welcome to all of you, and thank you once again.
Thank you so much, Doctor, for your valuable insights. We would now like to present a token of love and appreciation to Dr. Asha Rao. May I kindly invite Dr. Venugopal to come forward and hand over the memento to Dr. Asha Rao as a gesture of our heartfelt thanks.